Hello guys from wherever you're watching us from. This is The Connection. Manze, I'm really excited. You guys have really overwhelmed me with your love na kila kitu and I'm really excited. Kama kawaida mimi husemanga, hii show si yangu. Kama mko then I'm not there. So I see this is our 4th or 5th episode and we are still here going strong with your comments and everything. Tunashukuru sana. And everything that you guys are doing, from your comments, from your critics. Ninawaambia kama nyinyi hamko, mimi pia siko. And I will keep on giving you the best and the best content where we learn and we do every other thing. Sindio? So leo I have a guest who's come to the show. Kuna a lot of things that we don't talk in church about. Na hizo ndio vitu tunataka tu we connect you with, tuongee, you comment there, tujue, we discuss, so that at the end of the show we also learn and come with 1-2 things zenye zinaweza kutusaidia kwa life. So guest wangu leo ni daktari, is a doctor. I don't want even to talk much about it. Nini. I'll give him time to introduce himself. Sindio? Then so what we're going to talk about today is about HIV AIDS. Najua umeshtuka, ona vile unaniangalia. Yes, HIV AIDS in church. Unajua churches mingi we don't talk about these things and there are things that affect us each and every day. Kumbuka zile kitambo zile like when zilikuwa imekuja. Then maybe you've gone to visit someone, maybe in a church group ama any other place. You guys have gone to visit someone. Then ikifika mmeenda mmemuombea, mkosole, mmeboeka, mmenyamaza hivi. Alafu kidogo sumejua after hizo visitations zenye zinakuanga church, umekuja sasa umenawishwa hapo, umejonga sasa kuna kamkate kanakuja na kachai ama whatever the guest ametengeneza. Na mimi ndo kwa nyumba ya mtu mwenye ako na HIV and AIDS. Hizo days, I'm talking about those days, times zilikuwa zinakam. So those days unasema hapo ndio ungesikia hata tulikuwa tumekuja tu, hata tumepitia tu hivi kidogo, hata tukukua tunataka kukula. Why? The stigma that came to it. Today we want to sort out, tujue hii HIV AIDS ilitoka wapi, ilikuja mbona ina kiwa, any other thing. And if you have any question in regards to HIV and AIDS, this is the show. Hapo kwa comments andika. Na kama uko na feeling yoyote, una feel like you have a sentiment, you never know where your comment will end up to. Inaweza end up mahali itasaidia mtu, someone who's infected, someone who's still protecting himself and every other thing. So that's why the connection is here. And hii show ni yenu. Na nitarudia hii show ni yenu. It's not even mine. It's you guys who do that. So before hata nianze, I just want to remind you one thing. Na hapo kwa subscription, ndio nimeshukuru those who have subscribed. Na washukuru sana. Mmesubscribe, we were at around 3.8. Right now we are heading to 5. And I know by the time tunafika episode tuseme hata 6-7 tukwe tumefika 10k. So subscribe, like, share, give your views, make sure comment. Usinyamaze tu hapo una enjoying show naka, because I can see maybe the analytics watu wenye wana watch show hawaja subscribe. In fact 94% of you guys are supporting but you've not subscribed. Guys, subscribe and support. Mkifanya hivyo you give us a lot of strength to keep on giving you this content, educating you and doing everything to God's glory. Sindio? So, image introduction alone nimeongea sana, and I will want my guest to himself ajiintroduce yeye mwenyewe, atuambie anatoka wapi, anaenda wapi, akona jina ingine ngumu that I can't under something. So, Maliuko, put your hands together for daktari mwenyewe. Doc, welcome to the show.
Thank you.
Yeah.
I'll help you pronounce the name.
Yes, please.
Andagalu.
Andagalu.
Yes.
You're a lawyer or something,
I'm
isn't it?
from Vihiga County.
Yes.
So the name, I'm not even sure what it means. So, but it's there, Andagalu, Ben Andagalu.
Okay, Ben.
Yes. Medical doctor. I do clinical research.
Oh.
Yeah.
Karibu sana. Doc, karibu sana. Hapa, unaona the set we are really trying, si ndio?
No, you're doing it.
I'm doing it.
Yeah.
Thank you so
really
much.
Trying, you're
we are doing it.
Yeah.
Leo, I don't know what you take, but we'll see. Before tumalize show, lazima ukunywe kachai. Waluya nimejua, you guys, ukiingia kwa nyumba. Hauwezi kosa thermos kwa nyumba ya Mluya. So, sure. Doc, thank you so much. I know you're always a busy person, and getting you and you finding your time to come to the show, I don't take it for granted. So, karibu sana. And I think we only had this conversation once. Pap, and today we are there. Actually, if there is one guest who has been easy for me to get, yanile, to cooperate well and time and what, actually, sijawahi fika studio mapema hivi. Ask them. Nilikuja nikwambia, guest wangu wa leo anakuja, keeps time. Nikakuja hapa 30 minutes before time, and I wasn't worried that by this time tutakuwa tumeanza. So thank you so much, Daktari, and welcome to the show. So one thing that you want to talk about today is HIV. It's a big menace. It has been over the years. We want to get to know where did this thing come from. Kwa church pia, we've realized in our churches, we don't talk about this issue. We've been, for some time, we've not. But nowadays, we've seen there are Sabbaths that are coming, like HIV awareness Sabbath, every other thing. And it's something that is eating our members up. It's something that is going on each and every day. And we need to talk about it, the problem, not by running through it. So today we want to get, just from the synopsis, just from the ground, where did it come from, this HIV AIDS?
Yeah, so HIV, so first we need to distinguish HIV and AIDS.
Yes, it's two things, okay.
Yeah, so those are two different concepts. So HIV, human immunodeficiency virus, that's a virus that causes disease. AIDS, acquired immunodeficiency syndrome, is a collection of symptoms that come about when you're infected with HIV. So HIV is a virus, AIDS is a disease. Okay? So many times when people say HIV, AIDS, they think they are synonyms. But those are two different concepts. HIV is a virus, AIDS is a disease. It's been with us for quite a while. But the first description of AIDS was done in 1983. So in the States, there was a group of doctors who observed patients who are presenting with conditions that you typically see in people who have very low immunity. So either you've received a transplant or you're receiving certain kinds of treatment that suppresses your immunity. When you are in that condition, then there are diseases that get the chance to attack you. If you're healthy, those diseases do not attack you. So these doctors saw this group of young men living together. They were part of what we now call the LGBTQ community. Okay, that was on the west coast of the US. So they got thinking, why is it that these young men are coming to the hospital with conditions that you would never see in young people? Okay.
Conditions is symptoms?
So diseases.
Okay, diseases, okay.
There was a specific type of cancer that they had on the skin. They were getting a specific type of chest infection, pneumonia, okay, that you typically don't see in young people. Okay. You would only see it in those who are getting treatment to suppress the immunity. So, of course, that got them thinking, why is it this network of young men?
Young people.
Okay. So then they started doing their own investigations. Is there something that connects all of them? So they're all members of the LGBTQ community. Why is it that they all are presenting with a very
rare condition?
A very rare condition.
Yeah.
So that got them thinking. They took blood samples, started looking whether there was any virus or bacteria or whatever it is that could be causing those symptoms. So in that pursuit of looking for what the cause is, they identified a virus that all of them had. So the virus was new. They had never seen it before. They didn't even have a name for it. So, but they were able to identify that indeed there was a virus. At the same time, in France, there was also another group of doctors that had also noticed a similar pattern as was being investigated in the US. These two groups were not communicating. They were doing all this independently.
Research.
Okay? Yes. And this was in the early 80s, 1983. It's only in 1985 that these two groups then got together and they even came up with with one name for it, one name for the virus, HIV, and also one name for the condition, for those collection of symptoms they were seeing, and they called it AIDS. But that does not mean that the first case was present in the 80s. If you, of course, now once the virus had been identified, tests were developed to detect the virus. Now people started going back to samples that had been collected in the past and started testing to see which is the oldest blood sample that has been collected that would test HIV positive. And as at now, the oldest dates to 1959, a sample collected in Kinshasa, DRC. Then it was called Zaire. So it means the disease has been there for a very long time. Only in the 80s, you had the number of cases had reached a certain level that now allowed people to start joining dots. Okay. So where from? Somebody would ask. Yeah. 1959, a sample that tests to 83. So what happened? So there are tests that are available now that allow us to try and see where this virus could have come from. Okay. This is something we call whole genome sequencing. So you take the genetic makeup of the virus and try and see which other viruses are similar to this virus. And when did they part ways? Okay. So the HIV virus that is in humans is quite similar to another virus that is found in apes.
Yeah, I was coming to because some of the guys wanasema like the virus came from monkeys or something.
Yes. So that virus is very similar to the one that's found in apes. The one that's found in apes is called SIV. S meaning simian. Simian is just a Latin term for apes. So then what is considered scientifically sound right now, the consensus is that humans, when I say here it's humans, so humans interacted with primates. How? In the Congo forest, for example, people eat apes, people eat monkeys. So you hunt for monkeys. In that process of hunting and butchering.
People eat monkeys?
Oh, yes.
Allah.
People eat monkeys.
Most of my people here, kwa crew, I highly suspect they come from Congo. So ukisema wanakula apes.
Yeah, that is an important source of protein.
With them.
Yes. So when you set up a trap to trap a monkey, for example, when you come get the monkey, of course, the monkey will not cooperate. It will not tell you, hi, let us go home with you. The monkey will fight. So in that fighting, there's scratching. Or when you're butchering, when you're slaughtering, and you can get pricked by a bone, a broken bone, and so on and so forth. So that kind of interaction allowed the virus to jump from apes to humans. Typically, diseases of animals are diseases of animals. Diseases of humans are diseases of humans. But then there are few diseases that are able to jump like that.
Okay.
So away from HIV, yeah, I'm sure you've heard of anthrax.
Anthrax, yes.
Yes. It's a disease of animals, but it can jump to humans. I don't know if you've heard of yellow fever.
Yes.
It's a disease of animals, but it can jump to humans. So in the same way, SIV then jumped to humans. Then it started spreading, but very slowly. You'll remember in this, let me say from the 40s, 50s, up to the early 60s, that's the colonial period, a lot of medical care was being brought to Africa, immunization. And in those days, sterilization of equipment was not standard. There was a lot of sharing of needles. So those are some of the things that allowed the disease to spread. Now, HIV, and we shall come to how it presents. HIV, the thing is, once you're infected, you can stay up to 10 years without any symptoms.
Really?
Yes. So if you don't have symptoms, then you are invisible to health systems. The hospitals will not see you.
So the normal one of going to VCT, then you pricked, ukapimwa, someone can turn negative and actually the person is positive.
No, so you can be positive, you can test positive, but you have no symptoms, no headache, no fever, nothing for almost 10 years. So if you're not sick, you don't go to hospital. If you don't go to hospital, you don't do anything to stop the spread, right? So that is how HIV spread, because of that long period.
That's a window period.
Yes. So unlike, say, malaria, if you're bitten by a mosquito today that had malaria, within 10 to 14 days, you'll have symptoms.
Yes.
Headache, fever, sad vomiting, and all that. But for HIV, from the time you get infected to the time you get the first symptom can be as long as 10 years. So
those people, you can't trace where you got HIV.
It is very difficult
to trace.
It is very difficult.
So it can be like you need today, then you're trying to like, whom did I mean last?
Unless you are very particular about who you interact with. If you're somebody who has multiple partners, then it just becomes impossible to tell where it came from. So that character of HIV infection, that for a long time you move around, you have HIV, no symptoms, that is what allowed the HIV to spread. And then it now came to fore in the 80s, when you now get that critical mass. Now it has spread quite a bit. Then somebody would ask, so why in the US weren't there cases in Africa? Yes, there were cases. There are doctors in Uganda in the 60s and 70s who were describing what was called slim disease. People just losing weight. And that is a typical picture. When you tell somebody AIDS, they remember somebody very thin, losing loss of hair. So there are doctors in Uganda who had described that, but then they didn't put two and two together. Okay? And they didn't even have the tests that would allow that kind of investigation. So it's just that when the doctors in the US noticed it, they had the resources, they could do the research, and then HIV was found. When a test became available to determine are you HIV positive or not, that is when now HIV testing became part of standard medical practice. And that is when we were able to now say that slim disease that we were seeing in Uganda, for example, was actually HIV. Now, in the 80s, that is when a lot of the stigma came in. Okay, I know your viewers understand Kiswahili, so I'll just switch a little so that you understand where the stigma comes from. Okay. Do you know what zina is? Zina.
I just know it from a sentence. Ugonjwa wa zina.
Zina. Okay. Yes. So zina in Kiswahili is when you have sexual relations with somebody outside marriage. Zina.
You see mpango wa kando.
No. Yeah. So mpango wa kando is a person. The actual act is called zina.
Kiswahili, I hope mmelan.
Okay.
Zinaa.
So now when you say ugonjwa wa zinaa, you see that implication.
Okay.
That you only get this disease if you are straying.
Yeah.
If you are having sexual relations outside marriage.
So if you go out ni zinaa,
yeah.
then ugonjwa wa zinaa related.
Yes.
Okay, I hear you.
So HIV together with all these other magonjwa ya zinaa, you now see where the stigma can easily come from, that you can only have HIV if you are unfaithful. Okay.
If you're faithful to one partner,
then you will not have HIV, and you see that is not the case. Okay. So even from the way we describe sexually transmitted infections, okay, ugonjwa wa zinaa, that already sets the stage for stigma.
True.
Nobody wants to talk about it.
Associated with that.
Yes.
Hata kwa line mkiketi kwa hospitali.
Haya, mwenye yuko na ugonjwa wa zinaa ingia room 6. So you know, so that is how stigma actually came. Okay. And not just because HIV is transmitted sexually, but then also the other major ways that HIV is transmitted is if you use, so like drug addicts, when they share needles, that is another way. So you see, HIV is not transmitted in the most glamorous ways.
Kwani, how long does this virus stay on a needle? Because I know once you pricked, umeka hapo kando, then even after 2 days, 3 days, if someone else is pricked with that, and how long does it live outside the body?
So outside the body depends on which object. Okay. So if it was on this table, for example, within hours, it will die because the table is dry. So the virus gets deactivated. But in a needle, a hollow needle, you know, blood can remain inside the so we call it the space, you know, for the needle to pass, say, the medicine or whatever. There's a hole.
Yes, a hole there
in the middle. Yes. So if there is a bit of blood inside there, then the virus can stay a few days, 3, 5, even 7 days. Okay. And most often, when drug dealers are sharing needles, so you inject yourself, and then you give your mate, the mate will inject. Okay. And usually before you inject, what do? You draw a bit of blood to make sure you're in the vein, then you inject. I hope I'm not teaching people how to inject drugs. And so then your mate will also do the same. So you see, that is a chance for.
Okay.
Yeah.
I hear you.
Yeah. So
from what I heard, it's how it's being transmitted.
Yes.
Number one, we've said sexually.
So sexually.
Number two can be a needle prick.
So so when you say needle prick, it's in the hospital. I am tending to a patient, and I'm trying to put a needle in the vein. Then you move, and I prick myself. Oh. So that we call it a needle stick.
So this one is sharing of needles.
Sharing of needles.
Okay.
So if you are to rank them, so there is sexual transmission, that is the most common, followed by, before the advent of ARVs, it was followed by mother-to-child transmission, where a mother transmits to the unborn child, then followed by drug users sharing needles, and then down there you have medical personnel when they either, or even a patient being treated by a doctor who is HIV infected. Yes, there are cases. There was a dentist in Europe who the only source that was feasible for that particular patient was this dentist who was not on ARV treatment and transmitted the virus to the patient. But those are very rare. So the most is sexual transmission. Right now, since we have ARVs, mother-to-child transmission has gone down, but sharing of needles is up there. So not the most glamorous way of transmission. So the moment you say you have HIV, somebody asks, okay, it's either zina, okay, or you're using drugs. I'll just come back to the issue of LGBTQ again. So why there was a lot of stigma also. So gay men, when you have gay men, there is and you'll allow me to use a bit of medical terms. There is what we call penetrative and receptive. In that gay relationship, there is somebody who provides a penetrative part of it, and there's a person who is receptive. So the person who is receptive is at very high risk of getting HIV compared to the one who is penetrating. So a lot of the HIV that was seen on the west coast of the US in those early 80s was among gay men. Now, if you're a man and you say you have HIV, first thing is, are you gay?
You're gay.
Okay, so are you gay or are you a drug user? So you can see where stigma would come from. Yeah, that the diagnosis itself was a diagnosis of shame.
It was just a bad diagnosis. It was just a bad.
I mean, people proudly speak that, I have diabetes, so I'll only eat brown chapati, or if you're going to give me soya, do not put sugar in it. Okay, or I'll walk with my sweetener.
But in this case now,
you can't go. I mean, actually, yeah. So it was a diagnosis of shame. Okay, even in places where people are not meant to be shaming each other, that is church. Okay.
After before we get there to the church, the bit I also wanted to ask was about the testing bit of it, because there are several types of testing.
Yes.
Which one actually? Because first of all, someone goes to the VCT, anapimwa anaambiwa kwa positive, aamini. Because we've had several times someone has been declared positive, later on negative. What really happens?
Yes. And negative, not for the reasons that have been in the news recently. Yeah. Okay. So HIV testing. So there, and this is for any disease, that is caused by a pathogen, either virus or a bacteria and all that. So there are two ways of testing. Either you look for the pathogen. In this case, you look for the virus, HIV, or you look for evidence in the patient that the virus was there. Yeah, we all remember when we were in school, somebody would write on the desk, "I was here," 1992 to 1990 something, right? So the tests that are available will either look for the virus or look for evidence that the virus is in that person. Okay, so tests that look for the virus are very expensive. So there's a group of tests we call PCR. So it looks for a genetic sequence. I'll apologize for using those terms, that is ascribed to HIV. Okay. So for that test, once you're able to show that the virus is present, for sure the virus is present. Okay. The test is sensitive, meaning you can have a positive test as soon as 7 to 10 days after infection. So why not immediately? So if you were exposed yesterday and you try to test today, you'll not get a positive test, even though maybe infection has set in. Why? Because usually the tests rely on there being enough material to detect. Okay. The example I would give is if you were to put 1 teaspoon of sugar in a cup versus 1 teaspoon of sugar in a thermos. So which one will be easier to check?
To detect
yes.
the one in the cup.
Yeah, it's because there's a lot more sugar per volume, right, compared to this one. So usually the tests rely on the virus having multiplied for a while so that there's enough virus to detect. Okay. Now, for the tests that now look for evidence that the virus is there, so you're not looking for the virus, but you're looking for evidence that the virus is there. So what is that evidence? So for any foreign body that enters the human body, our bodies react by producing antibodies. So if you are exposed to the HIV virus, if infection has set, the body will start producing antibodies. It's a slow process, and usually it would take even a month or 6 weeks or even 8 weeks for the body to have produced enough antibodies that now a test kit can now detect. Okay, so in those two groups, so remember the one that looks for the virus. This is an expensive test. It is done in a lab. It needs lab people who are trained to do that.
The test.
So it's a PCR.
PCR.
Yeah, and there are two versions of it. There's one they call DNA PCR and another one RNA PCR. The DNA, RNA, that's a genetic
So
material.
that one can detect in what span, the window period?
In days.
In days?
Yes. Days following infection.
For
following
exposure?
Yes, they are.
Okay.
They are done in Kenya. Right now, most, shall I say, what were provincial hospitals then. Right now, we are calling them county referral hospitals. Most of them have the capacity to do it. Yeah. So that is RNA or DNA PCR. For the other test, the one that detects antibodies, those are the rapid tests that we typically are subjected to when you go to a VCT. So they take a small drop of blood, they put on the kit, then the kit runs for a few minutes. Then you're told if it's one band, it's negative. If it's 2 or 3 bands, then it's positive. Yeah, so something like that. Now, with that test, of course, when it's negative, we are not saying that you're not infected. You could be in that period between infection and there being enough material to detect, what we call the window period. Yeah. So then there are other tests that do not need blood. You can take a swab of inside your mouth. It's called a home testing kit. So that one, the window. So for no,
spit.
No, you just swab. You just take a swab and swab the inside of your mouth and you wait for the results. Okay.
So does that mean you can get infected through kiss or something?
No. Remember once again, what are we looking for? Evidence.
Oh, evidence. Okay.
Evidence that the virus is there, not the virus.
Okay.
But to answer your question, whether you can get infected via a kiss, typically not, unless the person is bleeding in the mouth.
Okay.
Then it becomes a bit disgusting to be kissing. So those tests, they've been around. They are now, to answer the question, somebody tested positive, then you try and do the test again negative. A lot of those were clerical errors. You can imagine in the 80s, 90s how VCTs were busy. So sometimes a counselor would have arranged you in a queue. So there are 10 people.
People will go in with couples.
Yes. So then, since the test kits, some of the older ones would take a while to run. So you collect, and you arrange them on your table. And then you tell the people to wait. Okay. And then now when they're coming in, maybe there's one who went to the toilet and then came back. So the queue has...
You come and get to the other ones.
Yes. So a lot of that used to happen. Okay. So the false positives, what we call false positives. So even though right now we have a nice system that prevents that kind of thing, but in the old days when there were no systems, that was very possible. Somebody gets tested, a positive test is ascribed to that individual, or they go start praying, then they start treatment and all that. Then later on they wonder, how come I've never seen any of these other issues that other people have? Then a test is repeated and you find it's negative. So most of them are clerical. What was more common was a false negative. So somebody's told you don't have HIV, but indeed they have. Maybe the technique that the counselor used, or they were just simply in the window period. Okay. Which I think right now with the systems that are in place, that is not really a very, very big problem. Yeah, so that's how testing is done, and it has not changed much. The rapid test is what we've been using here in Kenya, even from the 80s and even now. We use PCR for babies because infants born of mothers who are HIV infected. So remember, if you use a test looking for antibodies, the babies get antibodies from their mothers. So you may end up detecting the antibodies that came from the mother. So then for babies, even here in Kenya, the standard is to use PCR. You look for the virus, not for the antibodies. Okay. Yeah. So that's the testing bit.
Okay. Something else before?
No. So in terms of other tests that are then available to confirm, okay? So we know we have the rapid kits that we use in the VCTs. There's a lab version of that test that is now done in a specialized lab. So those are the tests that are used to confirm. They're typically used so when you have blood donation drives, they never do HIV testing. Say, they collect the blood, then the blood is taken to the blood bank. So in the blood bank, they run tests. So they don't use the rapid kits because you can imagine if the kit fails to pick and you transfuse somebody with HIV-infected blood, that becomes scandalous. So those lab-based tests are then the ones that are used to confirm that the blood that people have donated is clean.
Sawa. I want us to move to speak kidogo because there is a lot of I'm learning a lot of things from you, Daktari. So maybe the other thing that maybe came to my mind, I think it's also coming to the viewer's mind, about the it's not curable, right?
Okay,
is it, or it's now right now the way things have evolved? It's
so I will answer that very carefully. So you see what HIV does? It so without boring your viewers, it integrates itself inside the human cells. So it becomes part of you. So the typical cure, if you want to cure HIV, it means you kill all the human cells. If you kill all the human cells, you die. Correct?
Yeah, of course.
Yeah. So so that is what makes it difficult to cure. Let me use that. Okay. So why am I saying that? HIV doesn't just target any cell. It targets the cells of our immune system, the system that helps us fight disease or prevent disease. Okay. So if you got rid of all the immune cells and gave somebody a new pool of cells, then theoretically you could treat HIV.
True.
Has it happened? Yes. There are two patients. There's one popularly known as a Berlin patient. So what happened was this person had HIV, but he also got leukemia. So part of treatment of leukemia, so what does leukemia do? Leukemia destroys your immune system, okay? Then part of the treatment for leukemia is you get a bone marrow transplant. So this guy, so he got a bone marrow transplant because of leukemia. Remember, he's HIV infected. He had lost all his immune cells. So he got a new pool of cells. And hey presto, when they did the HIV test, it was negative. And he has remained negative. So in theory, if you were to do something like that, then it is in theory possible to treat, to cure HIV. But that's a very dangerous way. You know that trying to remove all your immune cells exposes you to very many things, many diseases and all that. And then a bone marrow transplant itself is a very dangerous procedure. Your body can reject, or the bone marrow can reject you. So, that is worse.
It's a two-way thing.
Yeah, that the bone marrow will reject you and it will just kill you. So it's not a way that...
So tuseme ilikuwa ni bahati.
Ni bahati. It got repeated twice. When you talk about bahati and all these people call it what? Aviator, right?
Aviator.
Yeah. What are the chances you'll win twice? So it happened twice. And there's another group of patients who underwent that same procedure and they were cured. So in theory, it's possible. The logistics behind it is just crazy. It is easier to just take conventional ARVs that suppress the virus and allows you to live an almost...
You've now mentioned something. ARVs, actually, that was naona story na flow tu vizuri pole pole. ARVs, I can remember those days kitambo we would hear when I was still in primary, like, hizo dawa ni kubwa kubwa, like, we were like being threatened even high school, primary, like, if you don't take care of yourself, utameza hizo dawa ni, they were big. How, maybe the ARVs zilianza wapi, how did they look like, and so on.
So the first ARV, antiretroviral drug, that was licensed in 1987. A drug called...
Really? 87?
87, yes.
See, not things that zimekuja tu juzi. And then why you have people dying, like, losing their hair, mwili na kuji na konda. You could see those things, like, someone angekuwa na hivyo kupima HIV na macho aseme, huyu
lazima.
Hakunayo.
Hakosi.
Nah, there were ARVs, those 87.
No, 1987, one drug, 1987, the cost. And that was only available in the US. It was not available outside the US until, I think, the 89 or 90. So that was the first drug, Zidovudine, AZT. Okay. Then there are, of course, others that came along. Then very quickly it was realized you needed a combination of drugs. So you could not just take one drug. Why? The virus becomes resistant. Then, of course, with time, by the time you're getting to the 90s, there were quite a number, but you had to take them in combination.
So combination, you take this drug at this time, because I know you usually have times. So
yes. So first, a minimum of 3 drugs, but it could be 4 or even 5 drugs with very strict timing. And some of the older ones were terrible, really. The size of your thumb, 1 pill, and you're told to take 8.
8?
Yes.
Mara moja?
Yes. And strictly, there are those that you're told strictly every 8 hours. If you just miss, then you find the virus quickly develops resistance.
So this was just to suppress the virus?
To suppress the virus. Okay. Because the virus, it will always be there. What you're doing is it attempts to peep the drugs hit it. So if you miss, then the virus comes out. And when it comes out, if it has known what drug is circulating, it can change its form. Then when you attempt to bring the drugs, then it doesn't work.
Drugs zilikuwa ni tamu kama sweet.
Those things were terrible. First, the size, so you can imagine the size.
So I'm imagining something big like this.
Then the smell. There are those that smelled of burnt rubber. Like when you burn a tire, that smell. And it's not a hint. It's a very strong smell. When you open the container in this room, even your neighbors would smell it. So the smell was horrid. Okay? Those that smelled like burnt rubber, those that smelled like rotting fish. Okay? Then there are those when you swallow, you get a terrible metallic taste in your mouth. Okay? If you've ever taken Flagyl, and when you take Flagyl, you find you can't.
I feel like vomiting.
Yes. So you imagine you're taking this daily. Then there are those that gave you that changed how your fat is distributed on your body. Fat leaves your face and then accumulates around your trunk. So if you're a lady, you can imagine you end up looking like a super drum with sticks in it. So some of those older drugs, they were terrible. And then they were expensive. In the early, say, mid to late 90s, a typical combination in Kenya would cost you 300,000 a month.
And that's why people were dying. Like,
so 300,000, not the 300,000 of today that you can do on M-Pesa. 300,000 would buy you a brand new. So in those days, champions used to drive a 504.
Peugeot.
Yes.
Peugeot.
So, Peugeot. So that's how it's pronounced.
Peugeot, not Peugeot.
But, so, and that brand new used to cost 270,000.
Brand new. Hiyo ni yenye umetoa pale Bitidobi.
0000 mileage. So people could not afford this. Okay, it's only in the 2000s I saw the price come down to 60,000 a month. Then it came to 3,000, then 300 bob, and then free. But you can imagine in the 90s, people could not afford it. So the people were having a field day were miracle healers. Because so somebody tells you either pay 300,000 for the drugs, or I'll just take 10,000 from you and I'll give you a handkerchief. That when you wave like this, the virus will go away. You understand? So the treatment was available, but just not accessible.
Very expensive.
Very expensive. I mean, you take the drugs, you're even more sick than the way you are before. You started taking the drugs. So they were difficult to take. They were expensive. And even if you had the money, it was not easy to get them. You had to import, at least for Kenya here. In the early 90s, you needed to import. To import, you pay customs. First, there's a shipping. I mean, it was just chaotic. It was chaotic. Even the very rich could not access. So it was not even though there were drugs, it was not as easy as it is right now. Right now we have drugs, a combination. So you just take one pill once a day.
Once a day, a specific time.
Yes.
Still expensive?
No, to the patient, it's 0 shillings here in Kenya. To the government, of course, there's a cost because those drugs cost money. A lot of our HIV care has been supported by external, what do you call them? Development partners. Okay. I think early this year, there was that, or early last year, when a certain administration changed, there was hesitance to continue supporting the HIV program. That brought a bit of disruption, just telling us that our governments need to take up. So to the patient, it's 0 shillings. Of course, to the healthcare system, there's a cost to it. But it's not as expensive as it used to be.
And the drug is not that...
No, they are well...
The side effects.
No, they are well tolerated.
So because nowadays, you can't tell someone... You could see someone like this, this one is HIV. People will like... No. But nowadays, in fact, I've worked in hospitals sometimes, and you could see if someone is that sick... is having that until you wonder, you should look at the second time like, because they look even more healthier than people were even negative.
Exactly, because the messages that they get at the clinics. So you take your drugs, you eat well, take care of yourself. So they end up looking very healthy, more healthy than those who are not taking ARVs. They don't get the same health messages that those other people get. But that is why it is important to always know your status. Because now there is treatment available. So you have no excuse.
You just treatment is to maintain it.
Treatment is to suppress the virus.
Suppress the virus.
Yeah. Okay. And when I say suppress, it means if you stop, then the virus gets... Yeah. So you have to keep taking. You have to keep taking the drugs for life. Yes. There is no point in time that you'll have a treatment break.
Okay. Because I can see also time is going. I've seen recently the government has brought some, there's something that has come. So what do we call them? I saw those trucks.
The long-lasting, yes. twice a year. So,
how does that work?
Yeah. So there are many ways of preventing HIV. So of course we have the traditional ways: abstinence, being faithful, using of condoms, yeah. But then there's drugs. So you can use drugs to prevent HIV. And would call that, and there are two, let me say, categories. So what you call post-exposure prophylaxis. Okay, and then there's pre-exposure prophylaxis. So what does that mean? So post-exposure means...
After.
There was an event, you're concerned that you may get HIV, then you take quickly before infection sets.
Okay.
So that is correctly used in, say, cases of gender-based violence, rape. So, I mean, this lady was walking in town, somebody accosts her, she's raped. You don't even know the status of whoever raped you. So there are drugs that then you take, and you take them for almost a month, so to ensure that HIV infection doesn't get established. So that's post-exposure. Now there's pre-exposure. You are anticipating there'll be exposure. Okay? So you can take a drug that then ensures that you do not get HIV when the exposure happens. So what, and that is what the government was introducing recently, lenacapavir, as an injectable drug, and it has a way that it is. I'm not going to convert this into yes. So there's how it is administered. So it's an injection given under the skin, and then supported
under the skin. What do you mean?
So the injections, you can give it into the muscle. That is a typical injection that people are given in the bum, right? That one. And then there's under the skin, so you don't go inside the muscle. You take the needle and make sure it doesn't go in. So it's just under the skin. No, just right under the skin.
Oh, juju too.
Yes, yes. So not on the surface. You inject a little and take the needle under. So what you're calling subcutaneous. Okay. Just right under the skin. So then once you get that jab, then every 6 months you get like another dose. I don't want to say booster because you use booster with vaccines. So it is not a vaccine, it is a drug. Okay, so you get a repeat dose every 6 months, and that keeps HIV at bay. So you'd ask, so who are the people who are being targeted with this? So the first category are people in the commercial sex world. And it's a very difficult profession. So if you know you are at risk, okay, so you can go get that drug, and then it prevents HIV. But then also, there are couples. You find one person is infected, the other is not. They want to have children, and sexual transmission is real. So you can have that drug for the one with HIV negative to get that drug, and then that way it makes the process of getting children a bit safe.
Okay. There is a lot. Well, we'll call you for the second time, for the second show. Sasa, there is another bit. Stigmatization. And I want to bring it. It's a wide thing. But I want to bring it to the church. As I was beginning, if you had my intro, in church people don't talk about this thing. Just want you to maybe take a step by step. What were when it came, we have members in our churches everywhere who are infected. So the stigmatization, how did it come up and how did it grow, and where are we as at now? Yeah.
So just going back to the Kiswahili term I gave you, zina, that HIV had a non-glamorous way of transmission. And then also the disease itself was not glamorous in those days. Okay. So that is where stigma started. People don't want to say they're HIV infected. But then also, when you say HIV infected, people judge you. Because, so remember zina, that we're only getting it if you're in illicit, shall I say, relationships, or you're having contact that is not godly. Okay? So, and if you came out and said you're HIV infected, and especially for ladies, they would say, are these ladies promiscuous? So people hide. Okay? And then in those days, people did not understand transmission. So the example you gave, it was common. You go visit somebody who is HIV infected, they offer a cup of tea, you say, oh no, we are not hungry. Tulikuwa tunapita tu. Okay? Why? Because people feared they could get HIV by sharing utensils, for example. and there was no treatment, or the treatment was not available or was not accessible. Let me use that term here. So then people fear. Everyone fears death. So those are the things that now started fueling stigma. And then our pastors, they would, when they talk about promiscuity, they will say, now you'll be promiscuous and you'll get AIDS. So that already makes it a taboo subject. And also going on the pulpit and talking about what people do between the sheets is, church is a family program. So, and people would feel ashamed talking about that kind of stuff. Because if you talk about HIV, the question is, how do you get it? Then you say it's sexual transmission. You have to talk about LGBTQ. Things that you cannot talk about on the pulpit. So those are things that, used to fuel that. But you know what? Right now, the church here in Kenya, the church, and this is the church in general, not just the Adventist church, Catholic church, other Protestant churches, they offer 30% of the HIV care here in Kenya through their facilities. So, and you can't provide HIV care with a lot of what we'd call mapepe. We are holy, here we are just, no. You have to address all those things. How is HIV transmitted? The issues of LGBTQ. You cannot stop somebody who says is gay from attending your clinic. You cannot say that, because we are in church, we don't want to see sinners here. Church is for sinners, right? So right now, the church, we have come from far. There are still pockets here and there where people either take advantage of people who are HIV infected. You want to make money, you want to make a name. I will not mention what has been going around the news, where people now want to show how powerful they are, how spiritual they are by being able to cleanse people of HIV. So we still have quite a bit of that, but we've come from far. We've come from far. We are not where we were in the 80s and 90s.
I can remember wacha dhambi sijui kilala na nini. It used to be so harsh. So I could imagine, what about those patients who are maybe HIV positive? Will they really come out? And I think that in one way or another will increase the spread of the virus, maybe, because people will not go for testing. Nowadays, even in church, guys are encouraged. During camp meetings, during any event, there's always a VCT place where guys go talk, which is a really big stride the church has made on it. Okay, so maybe as we wind up, the church has now embraced it to the extent like there is one church that I know which you have HIV awareness Sabbath. And I think also we'll really want to encourage also other churches to embrace it. Let it have a day, like people talk about it freely and every other thing. Maybe your thoughts as you end up?
That is a way to go. HIV is an infection just like any other. Only it has different social facets. Just going by how it's usually transmitted. So those facets, they have not changed. But we have to talk about them so that people know how to keep themselves safe. Or if you have HIV infection, how to take care of yourself. And we have a lot of health messages, and especially within the Adventist church, what to eat, how to live, Then there are those around you. If you're HIV infected, there are those around you who are your significant others. So how they handle that. When you're unwell, those are the same people you'll rely on to ensure that you get quality care. So, and church is where all types of people come. Okay, church is not a club. Everyone goes to church. Okay, it's not a bank, or it's not some high-end club somewhere. So you get a lot of reach. If you have HIV programs in your church, it means that message can go to as many people as possible.
Okay. As we wind up, maybe the last question. There is a viewer who's watching you and has really learnt a lot of this knowledge and every other thing. Someone is infected, someone else there at home watching us someone there at home is infected. Some of them are not even infected, and they are watching you. What would you like to tell them as a...
So HIV right now is a condition that's manageable. We have treatment, we have testing available, we have very experienced providers who will ensure you get the best care. So the first step is know your status. And knowing your status doesn't mean that you are behaving badly. Just knowing your status is part of knowing your health. Okay. Once you know your status, whether you're positive or negative, where there's a package of information that you will get from any VCT that you attend, a package that will help you live with the virus if you are living with the virus, and a package that will help you to prevent infection if you are not living with the virus. So I'd encourage you know your status and take the appropriate action based upon the test that you get.
Back to me. Wow. You've all had, yeah? Check your status. HIV is not a death sentence. Nowadays, there are people who live with it and may survive. So, guys, get tested, talk about it. Go to VCT, fanya nini, everything that you need to do so that you don't infect your significant other. Kitu ingine tena, let's remain faithful. Let's have one partner while we're on this journey so that we reduce or we suppress the virus being spread every other way. Let's talk about it in our churches, the youths, and every other person. So guys, I hope Melan, I've really learned from this podcast. Na kama umelearn, hapo kwa comment, make sure you andika kitu just to show us that we are together. Na ukiandika hivyo, the next segment, the next episode, nita mention your name, we'll read it with you, because you never know how it goes, yeah? So, like, subscribe, share. Until next time, may God bless you. Oh, by the way, before tumalize, do you support any football team?
Yeah, so surprise, I don't follow EPL. I usually hear Man U, all that, yeah. What I tend to watch is rugby and ice hockey.
Ice hockey.
So,
in Kenya, is there ice hockey?
No, there's none, but there's a very strong league elsewhere. So, so that's what I watch, ice hockey and rugby. I used to watch tennis, but nowadays the interest has, so Man U, Arsenal, I don't know, Crystal Palace and all those.
Other AFC Leopards.
No, we usually know when we've won.
Okay.
And when we lose, we also know. Yeah, but I'm not a very ardent soccer fan.
Music, your favorite?
So there are two things I could say there. I like some of the old Christian music.
Those are hymns.
I like South African music. Joyous Celebration is a group I really listen to. And now for Joyous Celebration, I play the bass guitar, so I usually play along.
Oh, you play
I listen,
guitar.
yeah,
Okay.
I listen and play along, so I really enjoy that thoroughly, yeah.
So your favorite hymn maybe that will cheza kwa hii show tuone.
Hymn number 1 in the Adventist hymnal.
Hymn number 1. Okay. You find it out. Do you know how it goes? Let me put you to...
Yeah, if you have the hymnal, I can sing.
Crammed it.
No, I have not crammed it.
So I think we'll play it later on. But guys, thank you so much for supporting our show. Tunawashukuru. Kama kawaida nasema, kama mko, mimi siko. And if you have another guest, a certain topic that you want us to discuss, tuweke hapo, andika hapo kwa comment. We have numbers, we have an email there. You can write to us so that we reach you, we hear your story, tell your story, so that someone else can learn, can save a life. That's simple podcast. You can save a life somewhere. So with that said and done, I'm really excited. I know you've learned. If at all you'll need doc again, perhaps you can just write to us. We'll connect you to the daktari. Alafu we'll know, so that tusaidiane. You are in a church, you want doc to come and speak to your youths, you want doc to speak to your parents, the teenagers and every other thing. Just write to us. We'll connect you to the daktari, and everything itakuwa sawa sawa. Thank you for your support. I'm really overwhelmed. Until next time, may God bless you and keep you until the next episode. Bye bye.